Welcome, everyone. We are very excited to have you all joining us for our new collaborative care series on interprofessional education and collaborative care, with a specific focus on what is sometimes called the allied health professions. All of the different professions that are dedicated to healing and ways that we can work together. And that is the goal of today's session. Before we begin, I want to invite you to join with me in a land acknowledgement. You can see on the bottom right, placenames.mapdev.ca is a website that we encourage you to use in order to find out the correct Indigenous name of the location where you are joining us from, and I invite you to put it in the chat. And if you want to just take a moment before I read this land acknowledgement to either look outside at the land or close your eyes and think of a place where you feel most connected to the land, so that you can join me in a moment of deep gratitude for where we are. And so if it might be a beach, it might be a hiking trail, a park, maybe it's your garden. But wherever you feel most connected to the land, just take a moment to close your eyes and feel gratitude for that location. I would like to begin by acknowledging that I am speaking from Unama'ki, which is located on the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the Peace and Friendship Treaties that were signed with the Mi'kmaq, Maliseet, and Passamaquoddy peoples from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982, and they remain active to this day. Let us take this time to pause in reflection and gratitude for the land where we live and work. And as we pause in gratitude, let us also pause in gratitude for all who have and continue to heroically care and advocate for this beautiful land. May we join them in this sacred work. Let us ground ourselves in the wisdom of the land-based Mi'kmaq teachings and values that we must all begin to learn. Let us work to decolonize ourselves, our practice, and this community that we share by working for justice for all living beings as an expression of our gratitude for being here. Let us take a deep breath and recenter ourselves away from the violent ways colonization fills our world and fills us. Let us take a deep breath and work on letting go of the unconscious bias that is everywhere, inside and out. May our session today lead us to be in right relationship with this land and with one another. When we acknowledge the land, we must also begin to acknowledge the wisdom of this planet and align ourselves with its truths. We are all treaty people. So how does this impact what we do and how we do it? And how will it guide our work together today? The Nova Scotia College of Social Workers commits to translating this acknowledgement into action by seeking to implement the recommendations of the Truth and Reconciliation Commission's calls to action. We commit to doing what we can to becoming better treaty partners. We commit to learning and to unlearning. Decolonizing means healing intergenerational trauma to understand the ways that it has been passed down to us and internalized. Restorative processes can help us to heal because they integrate trauma-informed processes that recognize our shared wounds and that focuses on joining with others to break down intersectional silos and unite to fix the colonial systems and intergenerational trauma we inherited rather than pointing fingers. They are also the basis of just culture and safety principles. Safer social work practice means reflecting upon the ways that our positionality impacts what we do and how we experience the world around us. Let us take this moment to reflect upon where we are on our own decolonizing journey. How are we integrating self-awareness and restorative justice into our work and into our professional development? Decolonizing ourselves in our practice means recognizing the ways in which we are each impacted by the colonial system in which we all participate and from which those of us of settler descent continue to benefit. Each of us, depending upon our social location and intersectional positionality, are uniquely impacted or oppressed. For example, those of us from African descent were dispossessed and uprooted from their land and brought to Turtle Island against their will as part of the white supremacy and slave trade that fueled the settlement of this continent. Let us take this moment to reflect upon the unique impact of colonization upon each of us and upon our practice. Becoming anti-racist is a journey, and it begins with a recognition of the ways in which racism and white supremacy exist in this world, and understanding our ability to speak out, unlearn, and work to advocate for better conditions for everyone. The Social Work Code of Ethics advocates for anti-racism in our practice. And so we commit to using our professional development to both learn new ways of thinking and understanding the work we do, and to unlearn assumptions and bias so that we can ensure safer social work practice and a more just world for all people. We are grateful for this new Canadian Association of Social Workers Code of Ethics that requires us to shift from the illusion of neutrality to actively becoming anti-racist and fighting against racism and all intersectional prejudice that is part of colonization. Social work understands public health and safety as including the psychosocial, spiritual, structural, and ecological determinants of health. We understand that social work involves working with the micro or individual or family level, as well as the meso and macro larger systems within which we work. We also understand that safer patient care happens when we see the whole picture. And that is why we are so excited about today's collaborative care series, which is the first in a 4-part series that is specifically focused on ensuring safer care by learning to see through each other's lenses. So social workers have our lens, and we're excited to share our lens with you as I'm doing right now. And we're excited to learn from all of you of different disciplines and professions so that we can see the fuller picture, and so that that can inform the way we can join with you in transforming our existing healthcare systems into one where none of us are burnt out, because all of us are working together collaboratively. When we work and collaborate together, then it's not just one of us left to shoulder the full burden, which too often is the doctor or the nurse that is struggling to deal with so much patient care that is burning out right now. And what we want to see is a broader focus on collaborative care. Personally, my doctoral research was on burnout in healthcare workers, so I have a deep passion for this. And I oversaw safety processes across much of several hospitals in the United States, south of the colonial border. And so coming here, I'm so excited to get to work with my colleagues from other disciplines and other professions so that we can transform the way we think of healthcare, and we can work on decolonizing the silos that keep us from collaborating more effectively as we all collectively work to transform our existing healthcare as part of our truth and reconciliation commitments. And that is why we're so proud and excited for this healthcare series, Interprofessional Education and Collaborative Care. For those of you joining us live, please use the chat to not only acknowledge the Indigenous name where you are joining us from, but perhaps share your profession and some of what is drawing you to this conversation. If you are joining us afterwards through YouTube video, we hope you will join us for one of our other events. So this is the first of a 8-part series. There's going to be 4 panels and 4 virtual lunches where we get to network together, looking at best practices and strategies for self-care, getting to know each other. I'm especially grateful to the Association of Psychologists, the Canadian Association of Spiritual Care, the physiotherapists, the occupational therapists, the Recreation Association for joining us in our advocacy for collaborative care. In May, we're going to have a case study on heart disease and how our different health professions see it. And then in August, we're going to be learning how we advocate for one another. And then in October, we're going to be having a panel on decolonizing our care. But today is our first session on our first panel, and it's about collaborative care and how each of us are going to be able to see from our unique lens a different perspective on patient care. We will be beginning with Amelia Fletcher from occupational therapy, Dr. Caitlin MacArthur from physical therapy, John Hayward from spiritual care, Natasha York from the discipline of psychology, Don McDonald, therapeutic recreation, and then we will have a chance to hear from Kristen Anderson from the field of social work, who will be speaking from a Schools Plus perspective. And with that, I'm actually going to stop my screen share. And I'm going to invite Dr. Amelia to introduce herself more broadly. And we're so grateful to have you here. Thank you.
Thank you, Naj. Hi, everyone. My name is Amelia Fletcher. I'm an occupational therapist, and I'm currently working in the Nova Scotia Health, Mental Health, and Addictions sector. I'm also speaking today on behalf of NSSOT, so the Nova Scotia Society for Occupational Therapy. And I am speaking, so I have speaking notes from one of our other members who was unexpectedly unable to join us today. So I'm kind of speaking on behalf of him, on behalf of our organization, on behalf of occupational therapy as a whole. So many of you may be familiar with the scope of occupational therapy and the role that we play in our multidisciplinary healthcare system. But for those of you who may be less familiar, we are kind of experts in function and occupation. So occupation being the activities or tasks that people are expected to or want to engage in over the day. That could be anything from, brushing your teeth and self-care activities like dressing, showering, and toileting, to driving, to attending to your financial needs and banking, kind of all of the things that we do as human beings. And typically we think of occupation as work, and work is very much an occupation, but it's not the only one. So we often look at things from a lens of self-care, productivity, and leisure. Occupational therapists typically if we are trained, to assess and intervene with people at the cognitive level, the physical level, psychological, and social. Many of our interventions kind of cross over those gray areas. I know if any of you are familiar with the work that's happening in British Columbia right now, there's recently been some changes at the government level, or proposed changes around the scope of occupational therapy as it relates to mental health. And a lot of us are very strong believers that you can't have occupational therapy without mental health, because when we are able to support people in doing and belonging, be that from a neurological standpoint, maybe at the Nova Scotia Rehab, maybe that from a private practice sector, all of that influences mental health. So OTs typically work with clients across the lifespan, so all the way from developmental milestones with infants to supporting aging in place at home with our older Nova Scotians. We work with people to support their goals and their recovery, and we often work from the standpoint of, you know, our colleagues as well. So we often have some gray area in our scope of practice with our social work colleagues, our physiotherapy colleagues, our rec therapy colleagues, and our other mental health professionals. So you might hear some of that gray overlap today. Often you can find us in a variety of workplaces, so hospitals, outpatient clinics, we have community OTs in mental health programs, you can find us in schools, long-term care facilities, within the justice system. We work in non-for-profits and private practice. Like I said, work in the mental health and addiction system, so I'm the occupational therapist at the Mental Health Day Hospital within Nova Scotia Health here in the Central Zone. So my role, or our program's role, is to support clients in transitioning from inpatient psychiatry back to community so we can support an early discharge. And we also work to prevent admission as well. So if clients are starting to become unwell and it's noticed by their community team, we often see clients for programming to prevent admission. And on that note, I do want to take a moment to highlight that within our scope of practice is psychotherapy. So that's not always a well-known fact about our scope of practice. So as occupational therapists, we are able to use psychotherapy within our scope, just the same as our Masters of Social Work colleagues, Masters of Counseling, etc. And this is often forgotten and surprising to folks. So part of my role here at Day Hospital is facilitating a CBT skills group. Other common places that you'll run into OTs would be in rehab settings, so clients who have sustained spinal cord injuries, brain injuries, any type of physical injury, concussion, chronic pain management, chronic condition management, long COVID. You can also find us in developmental clinics for children, discharge planning at the hospital, schools, in industry. We kind of work in a variety of areas. And our interventions, like I mentioned earlier, are focused on the mental, physical, emotional, cognitive, and spiritual domains. When we do a full assessment with somebody, typically from like a discharge planning perspective, we're often looking at a number of those domains, not just one. And an environment is a big thing within occupational therapy. So we're often looking at changes we can make to the environment to support somebody in being able to participate in their activities that they find meaningful or their occupations. Here in Nova Scotia, and a lot of our current advocacy work that's happening is involved in getting occupational therapists working in more primary care clinics. As Naj spoke about, there's a lot of burnout and access to care issues in our current healthcare system, and we feel as occupational therapists that we're quite underutilized in that domain. And there's a lot of great research and examples across the country of how OTs and many of our allied health supports can support both patient outcomes and flow of care in primary care. So we are actively working on that domain of advocacy. I actually am leading the primary care piece. We also have a team member who's leading advocacy work in getting occupational therapists in schools and occupational therapists more consistently in long-term care. If anyone's ever interested in the type of advocacy work that we're doing around that, I encourage you to reach out at the NSCSW. We are happy to speak to anyone around that. Yeah, that is OT. So we kind of work everywhere and anywhere, and we support people in getting back to what matters most to them. And we always enjoy collaborating with our interprofessional team members.
Thank you so very much, and thank you so much for joining us today, especially last minute, to fill in the gaps where a colleague was unable to join. And some of you may remember that we had an occupational therapist join us not too long ago for Lunch and Learn on advocacy around long-term care and long-term care planning, and different ways in which sometimes occupational therapy could be really useful in thinking about the construction of long-term care buildings, and how sometimes rooms need to be configured with consultation from occupational therapy to think about how they will be used, because some buildings are being built right now for long-term care that people can't actually even enter into because it doesn't think of, for example, bariatric patients or other things. So very grateful to have you joining us, especially last minute. Thank you so much.
Take care, everybody.
Yes. So we are now going to have a chance to hear from Dr. Caitlin MacArthur, who also had an emergency come up. For those of you who are watching us on YouTube, perhaps later, this is being filmed in the midst of the great snowstorm of February 2024 in Mi'kma'ki. So all sorts of things have happened, and I might actually lose some power myself at some point, but hopefully not. So we are going to hear Dr. Caitlin MacArthur, who's speaking from physical therapy's perspective. And hold on one second.
Hi, everybody. My name is Caitlin MacArthur, and I'm an assistant professor in the School of Physiotherapy, and I'm also a registered physiotherapist. And I've practiced in several settings, including long-term care and outpatient physiotherapy. And I'm here representing the Nova Scotia Physiotherapy Association today. So my hopes and visions for collaborative care are to ensure there's seamless communication amongst professionals to support patient-centered care. So really making sure that the patient is at the center of care and that the team and is really kind of guiding their own care, and the team is centered around them, and that we have the right members of the team there to support their needs. And so that's kind of my second hope and vision for collaborative care, is that the patient is able to see or be in contact with the right provider at the right time. So knowing that care needs change and people change over time, they won't always need the same team members. And so the team composition might change. It might start off with 3 different members, and then some of those swap out and swap in, depending on how that patient's what they need at that time. So yeah, I really, my vision is that they see the right provider at the right time, and kind of all working together to make sure that happens. So they might not always need to see a physiotherapist, but when they do, I hope that they're able to see them. I also hope that as a team, we can work and learn from each other to support patients through their journey. So I think as healthcare professionals and as care providers, it's really, really important that we all continue to learn and continue to grow and continue to work together. And collaborative care is a really great opportunity from this to learn about what other people are doing, what other techniques they might be using or strategies they might be using to help the person along the way. And so that we really can kind of learn and grow together. That then also helps kind of my second vision of knowing when you might need to refer to somebody else or involve another member of the team, because then you'll know what they do and how they might be able to help. In terms of what physiotherapy contributes to promoting patient safety and how it can help decrease provider burnout, is we are experts in movement and function. So we achieve this expertise through multiple different ways. So we can assess physical impairments and strengths of people through various assessment tools that we have. We can also prescribe therapeutic exercise and promote physical activity and a healthy lifestyle. We sometimes also use manual therapy, so hands-on techniques that we do with people, as well as the use of modalities to support return to function and to optimize function. Really, our goal is to keep people moving regardless of their abilities. So we are experts at modifying things, changing things, individualizing, tailoring to help people continue to move how they would like to and how they're able to. And really, we aim to help restore function as well as managing pain so that people are able to do the things that they want to do from a movement perspective. And so that's, all of those things together, we really promote people being independent as much as they possibly can, having autonomy to move throughout their lives as they wish, which really supports their safety and supports them throughout their communities.
And with that,
Hi, everybody. My name.
sorry, we are grateful to Dr. MacArthur for sharing, and now we're going to have a chance to hear from John, who is the executive. Well, I'll let John introduce himself.
Thanks, Nash. I appreciate this. This is a very exciting collaborative meeting. I'm glad that you asked me to be part of this, and just appreciate it very much. So very nice to meet everybody here. I'm just coming at perspective from the spiritual lens and the discipline of spiritual care. And just to give you a little bit of a background of who we are the Canadian Association for Spiritual Care. We are the membership organization and certifying body actually for those who are working in the profession of, as you would hear, maybe chaplaincy, but the term that we're using is spiritual care practitioner or spiritual health practitioner. And we have 1,250 members across the country. We work primarily in the healthcare setting, which is most of our members are working in spiritual care departments across the country in most hospitals. And in order for them to be working in the hospital environment, it is required that they do have their education through the Canadian Association of Spiritual Care and have at least 2 basic units to get in. But prior to coming into our courses for units, one has to have a master's in psychology or theology to begin the process of going through our units and our training. Like I said, most of our members are working in spiritual care departments across the country. And the one thing that I'm advocating for is a collaborative approach in regards to the interdisciplinary frameworks that we operate in. And coming from the spiritual care lens, and I really want to make the distinction because we do collaborate together with all the disciplines within the room today. But sometimes there's a little bit of a misunderstanding of the difference between religious care and spiritual care. And just to give you a little bit of background on myself, I was in 19 years, I was in full-time pastoral ministry across the country and also overseas in Asia. And then made a shift out of that sector into the not-for-profit sector and went into work with the Canadian Cancer Society, eventually became the director of Relay for Life, also worked over at the Alzheimer's Society of Canada and was the chief development officer for Canada. So had my footing in the spiritual world, but also in the not-for-profit and the executive world. And so coming over to the Canadian Association for Spiritual Care, my role is to develop the partnerships across the country to see where we can work more collaboratively with a clear understanding of the care of spiritual care, of finding those that are clients of ours, whether they be in a hospital, whether they be in a long-term care home, palliative care, whether they be in Corrections Canada or in your local provincial prison system. Wherever there's a spiritual care practitioner or chaplain, they are most likely working through our organization and through our training opportunities to become certified, and eventually they become supervisor educators. And you'll notice this in some of your locations where you work in Nova Scotia, where you'll have a supervisor educator from the spiritual care department have a cohort of about 6 students, where they would do their didactics and do their clinical or their practicum in the hospital in which they work. So what's important for us is that our members come in to the table. They're not community chaplains as such, where they come in and they're a Baptist minister or they're a Imam or they're a Jewish rabbi or they're from the Buddhist Society or humanist. We have all those members within our organization. So we're not religious based as much as we are spiritually based, where our members are trained to walk into a room and to be a presence and do some form of assessment as far as the spiritual distress. And coming from the angle that, all of us in our profession want to advocate for our role in social work or whatever, it might be a nurse or it might be another discipline, but we always advocate for our work. And so my role is to advocate that Canadians across the board have access to spiritual care when they're going through their times of distress and questions and the bigger transcendent type questions of why and what's happening to me? Why am I going through this? And so as we collaboratively work as interdisciplines, that there's some form of relief taken off the client in their distress as they go through spiritual distress, because it's hard to identify, but our members are trained to do that form of assessment through a spiritual lens and to identify where those stresses are and to actually chart that and to work with the interdisciplinary team in the rounds as they discuss the wholeness of care for the client. And so I was just in Nova Scotia just a couple of weeks ago, and I actually had dinner with Naj, and we were talking about spiritual care in Nova Scotia, and we had experienced some challenges with our clinical psychospiritual education in Nova Scotia, but that's been stopgapped, and we're going to continue that way. But it's so important for us to understand the demographics across this country of those that are identifiable in a religious setting where they go to the hospital and they need some form of care from maybe the religious leader or somebody from their religious community. But we know that today in Canada, most people don't identify with any form of religion. I mean, they don't, but they still are humans that have a body, mind, and a spirit, and that has to be navigated for the wholeness of care. So what I really like about this is for there to be a clearer understanding of who we are as an organization and to understand where those opportunities are to work together on the wholeness of care of a client that we're providing service to. And it the more we do this together, the more we collaborate, I feel the better it is for the client in which we serve. And considering Nova Scotia, one thing I did notice in Nova Scotia is a large amount of immigration. And where are these people coming from? What are the needs that they're bringing to the table when they come to Canada? And it's like when I was sitting down with some people from Nova Scotia, either we have to deal with the spiritual care in an organized, structured way, or we're going to have to respond to it as the need comes in, and then we're just kind of reacting to what's coming in and not actually structuring ourselves and how do we provide the wholeness of care, kind of removing the religious component, but understanding that people come in with spiritual distress. And if we can help alleviate that, it's good for the client, and it's also good for the other disciplines, because sometimes a nurse or a doctor are not skilled in the core competencies of delivering spiritual care, but there's professionals that come in and are able to do that assessment and provide a map of care moving forward. So Naj, I really appreciate this conversation. It's one of many to come, but I just wanted to introduce myself as the Executive Director for the Canadian Association for Spiritual Care. And I want to challenge you to kind of not think of religious care of, oh, there's a Baptist person, I need to call in a Baptist pastor or a Jewish rabbi, but to understand the skill of spiritual care practitioners are able to navigate and to be a presence and to walk into a room and help navigate that distress, even though a client may not be able to identify it, but it's there, and the care actually can speed up when people are dismissed. It's not the word. When they leave a hospital, it can help the process move it along. And so when you have administrators looking at what can help a person get out of the hospital quicker, sometimes we're looking at KPIs, but we have to measure spiritual care as well to see it as an asset to bring a sense of calm, to bring a sense of direction and a clarity in the midst of distress. So my name's John. I look forward to working with all of you. Thank you very much. I'll answer any questions down the road if you have.
Thank you.
Thank you.
Yeah, and there are some questions in the chat as well around spirituality and how that is explored in goals of care. Many of you may not know, for example, that there are evidence-based spiritual care assessment tools that exist. And you're welcome to contact me if you're interested in that. But when looking at spiritual care as opposed to religion, which John talked about, that the unique differences of those two, while chaplains or spiritual care providers can help support people needing religious diversity, are often the ones advocating for Indigenous patients to be able to access smudging and other resources that would help them in their healing. there's also additional counseling specifically in the healthcare setting and specifically in terms of ways of ensuring not just care for patients, but also other staff members. So there's actually been some interesting research on how spiritual care providers support members of the other interdisciplinary team and can reduce burnout. There's a lot of other comments and questions. We'll let that continue to go as we continue with the panel, but we will hopefully have a chance for more questions at the end. I'm really excited to invite back to our professional development series. Some of you may remember Natasha, who joined us earlier this summer, and I am going to invite her to introduce herself now. Thank you so much.
Thank you, Naj, and I'm grateful to be here in person instead of as a recording this time. As you can see, I'm in a strange location because I'm a school-based psychologist and I'm joining from a school. So my hope is lunch has ended and hopefully the noise level will be conducive to being here. If it does get loud, I'll just have to mute myself. I'm joining as a psychologist who's here both as a representative with our Association of Psychologists of Nova Scotia, APNS, but also as president of the Psychologists in Schools Association. So already I'm wearing two hats. So to begin, APNS is an association that promotes psychology as a profession, as a science, and as a means of promoting human welfare. But the field of psychology, which as you listen to John and Amelia and others, there are lots of things where you can see we're already overlapping and branching between professions. So we are experts in understanding, explaining, and changing behavior. We study how people think, or how we, because we're people too, how we think, feel, and act. And so, as I said, I'm both a school psychologist, but a member of a larger association of psychologists in the province. And we can be found in many, many spaces between schools, hospitals, the private sector. Our skills and focus is wherever you find people, you can find psychology. Unfortunately, you can't always find psychologists because, again, like many other professions, we are struggling with meeting demand and the numbers and whatnot of the need around mental health. So just in terms of overall vision and hope to be part of a collaboration from a person who's primarily in a school setting within the sector of the public school of Nova Scotia, we are already collaborating with interdisciplinary pieces around lovely to have occupational therapists in schools, physiotherapists, speech and language pathologists, social workers, of course. And that's always with, the goal of making sure that we're doing the most collaborative care we can for students. However, even within the field of psychology, we don't necessarily get the opportunity to collaborate within our own profession. Like I said, when you're within a system and then you have other systems, as everyone knows, there's the healthcare system. And so we have kids going back and forth from school system to private or hospital-based sectors. And that collaboration isn't always good, even within the field. So we definitely have a lot of work to do as far as tearing down the silos that exist between systems. We also have the levels of things that are changing that happen at a governmental level where funding is pulled or funding is placed in different locations. And so then you're reconfiguring, and I think it was Rose who put in the chat about those pieces where there are overlap or changes and professions. those lines can get blurred, which is definitely has those positive things. But as Rose mentioned in the chat, it can also be very confusing to know where one person ends and the next person begins, or service. And I feel like that's something from my perspective, we see a lot of trying to do the advocacy and the support of families, is families are then confused as to where am I getting what and how am I accessing, and can someone just please help my child? And so within this system, the advocacy piece that others have mentioned is a big part of our role as psychologists. So I feel like whether it's a psychologist who's working in a private practice, or it's a psychologist who's working in the healthcare sector or the education, we're advocating for our families and our clients. And so we're doing those pieces as kind of a primary focus. But psychologists could be doing work at the assessment level. So getting pieces of assessments for like learning, or for people in the criminal justice system, for people at various stages of their lives. Like that's definitely one piece that we see again through all of our professions, is that it's a developmental lifespan that we could be involved from birth to death and beyond, in terms of supporting people through the grieving process. And the piece around how government funding kind of becomes part of all of this is that it seems like we have a push in our province right now to have things very centralized, and one model kind of fitting all. And for those of us in rural parts of the province, we know that our access to supports and to collaborate is kind of, we need to do that as a backbone in order to survive, because a lot of the services are few and far between. So we're already looking to that collaboration piece, and we're always encouraging that. So needs in Yarmouth versus Sipekne'katik First Nation versus Glace Bay versus Halifax or the province looks very different. And so we're often trying to keep the client at the center of what we're doing, but finding all of the pieces we can to bring together and promote wellness and health for our clients.
Thank you so much.
you.
And we have some good conversations that are happening in the web, in the chat, around resources around their evidence-based spiritual care assessment tools. And then there's some comments around the different ways in which people can access services depending on where we live. And that's something that you brought up, that is so important when we think about interprofessional care. And can everyone access interprofessional care in the same way across Mi'kma'ki? That is a question for us to think about. And Natasha, we've talked a little bit about, we're going to be having a panel that we're working in collaboration with the Association of Psychologists, specifically on neurodiversity and trauma, because so much of mental health does not yet address trauma and neurodiversity, and the unique role that psychologists have around assessing and helping us understand neurodiversity and different ways in which we are all wired and what that means. So many ways, but when we don't know how the unique skill set that one brings or the other brings, or the unique tools that one brings and the other brings, and sometimes each of us might feel like we have to stretch and do for everyone and everything, as opposed to being like, I am really good in this area, you are really good in that area, and I know who to refer for what and how, which is really the goal, right? There are interprofessional teams, but are we all able to make effective referrals when needed, or do we go outside of our own scope of practice because we think we're alone and there's no one else around? So that's one of the reasons why we're having this. And there's some great resources that are happening in the chat. But before I continue any further, I'm so excited to invite Dawn, who is going to help us think about a profession that is also less well understood, but so important. So thank you.
Thank you, Naj. Can you hear me okay? Yeah,
Yes.
perfect. Okay, and I just have to apologize if I take a little coughing fit. I'm just still recovering from COVID, so it's been hanging on. So I apologize if I have to mute myself for a little cough. So thank you again, Naj, for putting this together. I'm so excited to be here. My name is Dawn McDonald. My pronouns are she and her, and I am the past president of the Nova Scotia Therapeutic Recreation Association. So I just rolled off presidency in October, and kept some of the projects that I had began as president in my portfolio as past president. From a professional standpoint, I am a recreation therapist. Been in the profession for close to 22 years now. Worked across all different settings. Primarily the bulk of my professional experiences in addictions and mental health, both inpatient in Halifax and community here in Cape Breton. Currently now I am an instructor. I'm a faculty member at the Nova Scotia Community College, the Marconi campus, soon to be the Sydney Waterfront campus, opening in September. So we're excited about that. And I teach the 2-year therapeutic recreation diploma program. So that's just a bit about me. And as we get started, I'm here to represent the Nova Scotia Therapeutic Recreation Association. I did create a little PowerPoint because of, if any of you have ever met me, I'm a talker and I can get off track easily. But basically, we're a pretty new association, just formed in 2018. However, we've had professional associations in the field of recreation and therapeutic recreation since the early to mid 90s in Nova Scotia. But in 2018, a couple of those associations dissolved and we came together to have a united voice across the province for the field of therapeutic recreation. So the focus of our association is to advocate to government and other organizations around the field of recreation therapy. I will use the terms recreation therapy and therapeutic recreation interchangeably. I apologize. I know it's confusing. Those within the profession know the difference. Those outside the profession, it really doesn't matter. They're kind of the same thing. But we also do a lot of education and learning for our members, providing connections within and around the profession, and that includes interprofessional development and collaboration, creating standards of service and practice for therapeutic recreation in Nova Scotia. I may be coming from a biased lens, but I do feel that we are leaders in the field of therapeutic recreation across the country. I'll speak to that a bit more. So that is kind of our focus. Some of our bigger advocacy pieces right now are attempting to become self-regulated in the province of Nova Scotia. It's been a journey. We began that journey in 2003, figuring that it would be 8 to 10 years. We're still hoping that will happen soon. And also around advocating, again, as I said, for different service areas to have therapeutic recreation services, whether that be a therapist or an associate, and I'll talk about that in a moment as well. You'll find recreation therapists, recreation therapy associates, recreation therapy programmers in a lot of clinical and community settings. We're not everywhere we want to be, but it's definitely expanded. I've seen a lot of growth over the last 20 years, but in most mental health, physical rehab, long-term care settings, you'll find us. There's a few of us in schools, doing things like youth health center coordinators, those types of positions. So we're slowly infiltrating all areas of health, and we're excited to have the support of this group as we continue to do that. So what is recreation therapy or therapeutic recreation? I like to look at it from kind of 2 different lenses. It's not rocket science, the first part. We all know that recreation and leisure is important to our own health and well-being. The more purposeful and meaningful recreation and leisure in our lives, the healthier we are, the more connected to community we are. So that's one of the roles of therapeutic recreation or recreation therapy, is to ensure that whomever we work with, from the young to the old, have purposeful and meaningful recreation in their lives, because we know that will have them be overall healthier individuals. The other piece to it is using recreation and leisure as kind of that modality for change. So how we may work with folks using simple games to get them to engage, to get them to work on goals, whether that be around cognition. It's also about maintaining and improving physical health by being involved in recreation and leisure. So we kind of use that recreation and leisure interventions as that modality for changing, helping people reach their goals and objectives. So the ultimate goal of TR is to facilitate full and optimal involvement in community throughout the lifespan. Because again, we know how important that is to someone's overall health and well-being. Again, we're pretty proud in Nova Scotia for what we've been able to do over the last 3 decades or so for the field of TR in Canada, but in particular in Nova Scotia. Dalhousie University. So if someone is calling themselves a recreation therapist in Nova Scotia, you can be rest assured that they are a certified therapeutic recreation specialist. And what that means is that's just the trademark certification that we get once we complete our degree, our internship, and write our certification exam. So if you hear the word certified therapeutic recreation specialist in Nova Scotia, that equals a recreation therapist. And we're lucky that we have Dalhousie here in Nova Scotia. That's the first accredited degree program in Canada. It's a 4-year Bachelor of Science. There's actually only 2 accredited therapeutic recreation degree programs in Canada, one being Dal and the other being Lethbridge. And Lethbridge was actually developed to help our folks with our diplomas, in particular through NSCC, be able to continue their education through distance education to be able to become a recreation therapist if they so choose. We also have, now we have 3 sites that have the NSCC 2-year therapeutic recreation diploma. So folks that graduate from that program, which is a program that I teach in, they would be prepared for positions such as recreation therapy associates or recreation therapy programmers. Or if you're in long-term care, probably 30 other titles that all mean the same position. We're hopefully going to do some work around that to get rid of some of those position titles so it's clearer for people with whom they're receiving services from. The difference between a recreation therapist and a recreation therapy associate or programmer, we kind of like to look at the differences between an RN and an LPN. Our folks with their 2-year diploma still have an independent scope of practice, but more so when the needs are predictable and stable with the client, much like a licensed practical nurse. Whereas if the person receiving interventions has more unstable or complicated diagnoses and needs, then that care is usually directed by the recreation therapist. And again, we're biased, but we believe that Nova Scotia is a leader in recreation therapy education across the country. So people are often confused with their recreation therapy professionals. Are they a therapist? Are they an associate or a programmer? Associate's the title you'll mostly hear in acute care within the district setting, and then the recreation therapy programmer is the most common term for those working in long-term care. I just wanted to highlight this because it does show again how per capita we have the most recreation therapists of any province in the country. If you look at, I think Ontario has about, I was doing the math before, 15 million people. It was about one recreation therapist to every 50,000 folks. And in Nova Scotia, it works out to be about 1 in 5,000. So we recognize our uniqueness in Nova Scotia of having those high numbers of recreation therapists and then being able to provide that level of care here in Nova Scotia. So kind of the bulk of what we wanted to talk about today, and Naj was gracious enough to meet with me yesterday to kind of go over what should be kind of the points we're making today. He said the term thriving, not merely surviving. And I think that speaks to what we do in therapeutic recreation so much. Of course, we've talked about those gray areas, and all disciplines, work from a person-centered approach, want their clients to be more autonomous in their care. And that, again, is something that's really rooted in the practice of therapeutic recreation. So we want to improve health care outcomes, just like every other healthcare profession. And again, whether that's improving or maintaining in all areas of health, physical, social, emotional, cognitive. We can, if the positions were in the community, if the positions were in the schools, we have a huge focus on prevention, getting people involved, actively involved in recreation and leisure, has all those wonderful benefits that come with it, but act as kind of, I'm losing my words, protective factors for chronic disease, for mental health and substance use issues that may pop up later in life. The research shows that being involved in your community, having meaningful and purposeful recreation and leisure can be protective factors against many illnesses and diseases. There's many things that I love about therapeutic recreation, but the ability to build those authentic relationships with the clients in which we work. We're lucky in the way that our profession is set up that most times we're with clients from the time we walk in the door to the time we leave, whether that be running programs, doing one-on-one interventions. So that ability to build those authentic relationships really blooms, even if you're just sitting down to play a game of cards. Sharing those experiences with people enable us to build those authentic relationships. And in the teams that I have worked in, after they kind of understood what therapeutic recreation was, they would often come to myself or other TR colleagues within the team to talk about how was so-and-so in group today. Especially if there was a medication change, were they more drowsy? Were they less engaged? Were there any behaviors that were coming up that you haven't recognized before? And again, because of those relationships and being with people every day, we were often the first ones to kind of notice some of those changes that might happen from other interventions. When I speak to the students about the field of therapeutic recreation, I always talk about the privilege that we have to help people find their spark, that thing that makes them look forward to something in the day, that gets them motivated to get up out of bed, that allows them to make those connections with others, share those experiences with others, and how wonderful it is that it's a part of everybody's profession, but that's a main driving force of what we do, and what a privilege it is to experience those things with individuals. And again, use those to help them better their health and well-being overall. The last point I want to talk about is, if you have a TR professional on your team, they tend to bring the fun. I cringe on the inside a little bit when I say that, because for so many years we fought to show that we're more than just fun. We're more than just bringing activities to people. But we must remain rooted in our expertise, and that is around recreation and leisure. So not only do we provide purposeful interventions to help people work towards goals, we also provide activities for people to experience self-expression, to find new identities through recreation, fun, and leisure. One of my favorite programs when I was working in mental health was to take folks out and take pictures of them doing activities, whether it be kayaking or painting, to add to their self-identity. So I'm not just Joe with schizophrenia, or I'm not just Joe with substance use disorder. I'm Joe the kayaker. I'm Joe the painter. And to be able to add some of that to their own narrative of how they see themselves and describe themselves, and the beautiful changes that can come along with that. So yes, everything that we do is based in evidence and rooted in providing outcomes, but we really try to do it in a fun and enjoyable way that keeps people coming back and creating those relationships with us, because the stronger relationships we build, the more impact we can have on the care, working alongside our clients, helping them identify and reach their goals. And then, of course, with the end goal being improving everyone's health and well-being, the clients that we serve, but also the teams in which we work. Being able to provide assistance and support to our interprofessional team members. Yeah, so I guess that's what therapeutic recreation is in a nutshell. Hopefully, you were able to learn a little bit more about TR and the role we play within the interdisciplinary team. Thank you all so much.
Thank you so very much. And one of the things that there's some great conversations about the role of therapeutic recreation that are happening in the chat about the role that they play in schools, but also like in supporting people in transitioning, for example, to long-term care. Long-term care is often such a time when people have perhaps so much grief around loss of ability, around what does life mean. And while there's value in speaking and discussing and processing, being able to find new ways to have fun, new ways to play in a world where play is often discounted. And you spoke really powerfully about that, that we want to medicalize it, but now as we think about decolonizing, in fact, I had a social work student with whom I was speaking earlier today who talked about joy. We were talking about rest is resistance, which if you've not read the book, Rest is Resistance, I strongly recommend it. But joy is also resistance. Play is resistance. It's a way of healing ourselves that maybe we don't feel like we have a right to do, but your profession is helping to advocate it. And thanks for helping us see how Mi'kma'ki, unceded Mi'kma'ki, otherwise known as Nova Scotia, is a leader in the country on that. So we can be proud of ourselves and continue to advocate on that front. So we're going to now hear from our last speaker, who is also in the school system, who's a social worker, who's going to be speaking a little bit about her vision and understanding of collaborative care. And then we're going to have some discussion and I think answer any questions.
Good morning, everybody, on this snowy winter's day. I'm Kristen Anderson. I'm a super proud social worker and regional coordinator for integrated services for the Western Zone, joining you today from Quassawatic or Falmouth in the beautiful Annapolis Valley of Nova Scotia. I just wanted to take a moment to speak about integrated care and integrated practice and integrated service delivery. It is my passion. It is the work that I have fits with my brain and has worked with me over the last almost 20 years of my youth work and social work career. Currently, I work through Schools Plus Integrated Services, where we challenge and work with communities, advocates, students, families, and their supporters to put students at the center of their service delivery. And what that looks like depends on the student themselves, but it's actively working on collaboration and looking at the student's view and community's view around how we can support them to fit with their long-term needs and their goals, as opposed to how we can fit them into the programs that we have already available across government and community services. Across my kind of career as a social worker, I hear a lot about silos. And one of the challenges I have for all of us is to stop looking at the silo, but instead of how we can all wrap around and support and connect individuals and supports to what they need. Firm believer that people identify and can we can, with support and that first voice experience, understand what families, students, and communities need, and then work together to wrap around them in support of difference and change, and allowing individuals to live the life that they are hoping to lead. When we look at all of the different professions that have evolved, I think of, rec therapy, occupational therapy, spiritual care, child child specialists. There are so many different approaches to practice that are being identified, supported, and we're learning from other cultures and areas on how to embrace and support. And I think about what that means for the student or the youth at the center of their care. If they can see a child life specialist, an occupational therapist, a physiotherapy assistant, a social worker, a psychologist, a psychometrist, whatever that might be, it also allows them to dream about other populations within the healing professions around what they might want to do when they're older, and it really expands their scope and our scopes of practice. I learn more from students and communities and families as I go on my continuous learning journey as a social worker dedicated to integrated service across the profession. So my hope is that when you hear the word silo, your response is as mine is, in terms of that's not the period, it's a silo. It's the beginning. There's the silo. How are we working across profession, across culture, across community to be able to join together and wrap services around remarkable children, students, families in support of integrated practice opportunities. So sorry I couldn't be there. Thanks for having me. Hope this works. And as always, if there are ever questions, concerns, or challenges around integrated service delivery, and it is a challenge, sitting down, partnering, working through, identifying where your perspectives is, your ethics are, and working through some of those pieces. The other piece I encourage all of us to look at is stages of burnout. We talk a lot about when we're burnt. We don't talk a lot about the path to burnout, and all of those things impact integrated practice delivery, and our most vulnerable families and clients feel that. So it's a process, it's a reflective process, and I am with you in the struggles around how we continue to improve, support, and do better for the communities who rely on us most. Thanks.
Thank you, Kristen, for sharing some of your passion. Reminder before we pause for questions that Kristen talked about supporting self-care and stages of burnout, and a part of the vision of talking about collaborative care so that we can be aware of where we each have special skills and training so that we can refer and collaborate together. But we will be having March 6th from 12 to 1 breakout sessions for luncheon. We can just network and talk with each other about self-care, the best that we can do, learning from one another, how can we support, and then we're going to be looking at a case study. But the specific thing that was mentioned by Kristen had to do with the ways in which sometimes there are differences in, for example, code of ethics. It's not always easy. We've had some conversation in the chat. There's going to be actually in a little bit, in a few months, we're going to be holding another interprofessional ethics on duty to report and different perspectives on how we navigate that within a healthcare team. So lots more to discuss, but if there are any questions or any reflections, I think I saw John raise his hand, so I'll invite John to.
No, I was just thinking when Dawn was talking in regards to recreational therapy, and just hearing you speak about how that modality or that discipline can actually provide such care for somebody going through that. And I was just thinking, all of us come from that perspective, right? In regards to our spiritual care practitioners feel the same way. I just felt very collaborative type spirit in how we were chatting, that these disciplines don't operate in a vacuum. Like they're so connected to the other providers of care around our own discipline that it's so critical to the left right hand understands what's going on and how we function and how we all have a part to play in the wholeness of care. It was just dawn to hear you speak about that. Um, just brought in the whole word of collaborating and to understand how your work actually has impact on the client in which we serve, but also and just the collaborative work, how we can celebrate that. I find sometimes, and I appreciate the comment that just came out in regards to silos. It's yeah, that's a reality, but I think this is the trenches that actually can change that. And because many times, let's just say, for example, when people start to cut down budgets, and we all know healthcare's a very pressured place right now where budgets are cut, but really spiritual care seems to be the easy target. I'm going to be honest with you. It's an easy target because people say, well, we'll just go to a volunteer model and go back to the olden days where we just called in people. Like that's high risk nowadays in the culture in which we live, because a lot of damage can be done with unprofessional people going into a hospital building under the opposite of a spiritual care practitioner, but they're going in to save a soul or cause disruption, or there's so much risk involved. And that's why with RT that you're speaking about and all the other disciplines that are being mentioned here, the importance of skilled, trained professionals is critical in the spiritual care lens. That like I come from 19 years in pastoral ministry, understanding there's a lot of characters in that zoo, and to understand the depth of training and experience and what's required to provide that care is critical. And so I think a lot of the interaction that we have as a discipline is within the social work, like really, because when I went into Nova Scotia, all the directors and managers that are overseeing the spiritual care department are social workers. So if that discipline doesn't understand the depth of education and training our professionals go through, it becomes very difficult for you to advocate for us. And then I want us to advocate for you, right? So all these disciplines, we have to advocate for one another. And I just really saw a real example of how we can collaborate together, understanding the impact of our work together on the success of providing care to a client, and how we can actually, we do have data. It's how we collaborate that data together to see how spiritual care and these other disciplines are just not about efficiencies within the healthcare system, but it's the quality of care that's being measured at the end of the day too. Just a thought and celebration of collaboration.
Thank you. And thank you for highlighting the damage of volunteers. I'm sure Dawn can probably speak to that as well, but the importance of regulated healthcare professions, or of healthcare professions that have codes of ethics. Specifically, religion is probably a good one to think about, as we just celebrated the 2-year anniversary of the conversion ban, conversion therapy and conversion practices ban, and yet another reason why certified or trained chaplains and spiritual care providers, as opposed to a volunteer, would be an important thing. And if there is a volunteer that comes in, the chaplain is able to negotiate to ensure that there's no harm that is done, and working with the team. Dawn, John was referencing you, so I don't know if you wanted to say a few more words about either reflecting on the larger whole or in response to John.
Yes, thanks, John. And I've been lucky in my career that my work hasn't happened in silos. Like, I think part of being maybe a recreation therapist is you're probably the only one there. So you don't have that silo to surround you. So you have to reach out and have to, have those collaborative practice moments, because we can't do it on our own, right? Like I think of my work in physical rehab, and finding out that someone loved painting, right? But now we need adaptive equipment for them to participate in that. So going to the occupational therapist, right, to talk about, okay, this is the goals of the clients through the recreation therapy care plan. Can you help me? Can you help? And it was always a great collaboration between the occupational therapists and the physiotherapists and the rec therapists within physical rehab. And then my time in mental health and addictions, I worked very closely with social workers the whole time. A bit with spiritual care when I worked in a day program. We had a spiritual care therapist there with all the qualifications. So it was really great to see his lens as well, and how we collaborated in group programs. It was a day program in Halifax, and I got to co-facilitate groups with social workers and occupational therapists and spiritual care providers. So yeah, I think it's been happening, but now we can have this larger scale of really how to advance care through those collaborations, not just doing them because we have to do them to survive, but again, doing them so as teams we can thrive and really help our clients do the same.
Thank you. And I want to invite people to put more comments and questions in the chat if they wish. But one of the things is Dr. Caitlin MacArthur was speaking earlier about different models of care and patient-centered care, for example, versus system-centered care. So we could have like, oh, you go see this specialist for your elbow, this specialist for your knee, this specialist for here, this specialist for there. And the person's just going like this, right? So we are, as opposed to all of us working together for a full assessment of the person's needs holistically, recognizing that we are more than just our bodies and that everything is all intertwined, and then developing a plan of care with the people so that we can kind of work together collaboratively to create a method that also reduces burnout on providers, because sometimes we don't know. I don't know, for example, Dawn, I didn't know that I could, for example, work with my patient who has a neurological challenge, is losing the ability to move in ways that they used to, is struggling with depression, maybe doesn't want to wake up in the morning, and you could help them find a new purpose, a new way of enjoying life, a new way of connecting with family and friends by learning to play in a different way. The physical therapist could be assisting. That all of those different components are part of the larger human, and having that approach to care can be truly transformative. Natasha, you were in the chat talking a little bit about just the role of recreational therapy in the school system, if you wanted to perhaps say a few words.
Yeah, I just thought that sounds like a wonderful thing. I would love to have therapeutic recreation in schools. Oftentimes we're part of a team looking at long-term planning for students, especially, with complex needs. And leisure is always something that we bring up, and it's always like oh yeah, they need to actually have some leisure activities that they might enjoy. It's not all academics and it's not all self-care. That is a big part of a person's life, is being able to identify what do they enjoy doing, and how do we incorporate that into planning around their whole self in school. So I would love to see that, and I know that's not currently happening, but that would be a wonderful way to kind of collaborate again to remind everyone that that's a part of a person's whole well-being, and it's almost like an afterthought when you bring it up. It's like, oh right, yeah, people like to do things. Yeah, so that'd be awesome.
And especially when we think about how children learn, right? They learn so well through play. Self-discovery, and trying on different hats and different identities. And oftentimes in school, I mean, I'm from Glace Bay. We do a great job with getting kids into sport. And sport's wonderful. I love sport. But sport is still a very just small piece of recreation and leisure, and it's inaccessible to a lot. There's there's a lot of barriers created in some sports for people to be involved. And sometimes it's not even that true feeling of being connected with that activity through sport. It might be competitive reasons or other reasons to be involved. Sport is great. I'm not dissing sport, but we often think of recreation as sport, especially for kids, when they should be out trying everything to find out what it is that brings them joy, that they can use as you know, in times of need and in struggle and anxiety and depression, those activities they can turn to that bring them a sense of peace and normalcy and, you know, skill development and building. So
And
yeah,
community. Yeah.
yeah.
And community. Like we have our Yarmouth Comic and Gaming Convention, and it's just a volunteer thing I do on the side, but we bring people, lots of neurodiverse people together, and they find, you know, speed puzzles or whatever, you know, there's all of these things that people never even consider as recreation, which is so important. You're right. And it tends to be focused on like sport. So yeah, absolutely. And our early childhood educators seem to have a really good grasp of how important play is. And then they get into our school system and that kind of like, yeah, still important.
Yeah. I
An
think of
age
that.
out
I'm
of
sure you've
play.
seen the TED Talk. I think it's the most viewed TED Talk in the world, Sir Richard somebody, and he talking about how school kills creativity and play, right? And how important it is, and especially as we get to become adults, you know, that's almost seen as a negative thing, to be spending your time in play, when it's so regenerative, when it's so important to who we are as individuals. And I know, you know, approaching that mid-century mark, I have I guess a resurgence of how important recreation and leisure is in my life, especially for my mental health and my connection to family and friends. That happens through recreation and leisure, and it's sometimes the first thing to go, right? That focus on everything else. Yeah.
You know, I was just thinking that I have two daughters. They're 36 and 34. But anyway, my one daughter works at a marijuana manufacturing plant. She's a supervisor there. But anyway, their extended health benefits give her $3,000 a year for hobbies. Like does she like gardening? Then she can buy gardening tools, and that can be written off as a benefit to her. So they give her, like, what does she like to do as far as a hobby? Does she like to work out, buy weights? If you want to do this or a hobby that you like, just expense that and they pay it. I like that, you know, where that is becoming a focal point, that is part of the whole care of health. So yeah.
It's a smart business move because you're
Very
going
smart.
to have healthier employees because they're engaged in things that make them well, right? So
That's the impact statement now, right?
And this is where, first of all, when we can begin to think and dream together, right, we can reimagine what healing looks like. The chat has some great conversations around this. But so, for example, I was part of a community project several years ago that brought together long-term care facilities, communities of faith, recreation therapy, occupational therapy, social work, clergy, all coming together to assist, for example, people who are in long-term care who have perhaps mobility issues, speaking issues, and family members who want to connect with their loved one, but don't know necessarily how. And a big collective game night that was organized with kids, working with older adults, the intergenerational learning, and actually looking at the health outcomes of those older adults who suddenly had this thing that they looked forward to. We did it once a month, and it was like their lifeblood. It really improved all of their metrics. It improved their willingness to participate in physical therapy, all of those outcomes as a result of this large community event. Imagine what kind of collaborative opportunities there can be. This is what we can begin to dream together at our next event, so that we can continue to dream. This is just the first of our series. So I'm going to just put this here as our closing, but we will be having on May 2nd a case study on heart disease. On August 16th, how do we advocate for each other when we're working with a patient? How do we recognize that this person or this family or this community could benefit from a discipline other than our own? How do we begin to advocate for one another? And what does that mean in terms of decolonizing our care? We will be having some Mi'kmaq voices to join us in that, but also just even removing silos. The concept of silos is part of colonization. And then what does this look like? How can we build relationships together? March 6th, June 5th, September 17th, and November 6th are going to be lunches, 1 hour, just breakout sessions, sharing strategies for self-care, getting to know each other. And hopefully at the end of this year, we are going to be getting to know each other better, understanding the unique perspectives of each other's disciplines, and hopefully beginning to see a transformation in our healthcare so that none of us feels alone, isolated. It's just me and my discipline. How am I going to see everyone? How am I going to heal all of the many complex issues? Am I trained in spiritual care? No, but maybe there could be all sorts of people, or maybe we could, I didn't know about the recreation therapy. I myself am struggling with how do I find something joyful to do, right? So grateful to all of you who have joined us to share. Thank you to everyone who stayed for the chat and participated. Thank you to those people who pre-recorded and weren't able to stay for the whole conversation. But if you are joining us on YouTube later, we hope to see you at our next one. And may our collective conversations transform and save our healthcare system, and perhaps even help us go from surviving to thriving. May it be so. Thank you, everyone. And may you go and do something fun some point today and think of Dawn and whatever that fun looks like, may it be a spark that you can then share with others. Thank you, everyone. Bye.
Thank you.